On this episode of the Ask Mike Reinold Show, we are celebrating our 50th episode. That wasn't as exciting as I thought that was going to be.
I couldn't clap.
We have a special 50th episode. We have a very, very super duper special guest appearance from someone that's going to ask us the questions. You'll have to watch and see. And we're going to answer a few questions. We're going to talk about certs for new grads. We're going to talk about shoulder biomechanics and about chronic pain. The Ask Mike Reinold Show. Helping people feel better, move better, and perform better. Welcome back, everybody, to a very special episode of the podcast. Today is officially our 50th episode.
Wow.
So, congratulations.
50th episode.
50 down and 50 to go, but it's been a crazy year. I mean, we've been doing one a week for almost the entire year, so we're pretty much there. But crazy year of sharing and answering some awesome questions on the podcast. So thank you guys, thank everybody here for being a big part of it. Be sure to subscribe. Go to the website MikeReinold.com. Click on the podcast link. Ask us more questions. We love the questions. Subscribe. Give us a sweet review on iTunes. That would be great. But yeah, congrats to all you guys. Thanks for everybody being a part. We have a very, very special episode. So
we're all in matching uniforms.
Yes. So we all got dressed up for our.
Mike, what are you wearing to the podcast?
So we all coordinated our outfits today. But what do you guys think? We all wore the same outfits. Wow. Is that pretty cool?
We'll look off.
Pretty solid. Pretty good. So we all wore the gray and black today for some reason. That was unintentional. We're going to pause in there. Len, this is the deja vu. Len, what's the statistical probability of us?
Well, we always wear blacks or blues or grays, so there's a very good chance. So there's four of us to the fourth.
Three variations of polos.
So do we square root that?
To the square root of three variations.
88 miles an hour!
Inverse relationship.
The flux capacitor.
There's a 50% chance.
Statistically, it's very challenging.
What time did the train mean?
It's statistically very challenging for us to all have the same outfit on. So congratulations, you guys. Have a very special and lucky episode for our 50th episode. But more importantly, we have an amazing special surprise for you guys. We've brought back the one and only, our very first student to work with us on the podcast that we all know and love. Am I building up the suspense?
I'm so excited. Who is it?
And I have one more amazing announcement for you. The Gabenator is joining us. The Gabenator has agreed to join us for the podcast this episode. He is coming in via FaceTime and doing a little heads-up display, and he's going to be asking our awesome questions today for the podcast episode. To celebrate the 50th, we wanted to bring Gabenator back on. So Gabe, before we get going, what's up with you, buddy? What are you doing? What's your life like?
Well, right now it's about 70 degrees outside, sitting out here in Phoenix, Arizona. A little different than Boston, I will say that much, but things are going pretty good.
Awesome, good. So what's in tap for you now, man? We heard you're moving back to Georgia. What's going on? You're a physical therapist. You graduated college. What else is going on?
Just trying to learn as much as I can, be a new clinician, trying to find the best fit for me, and then just move my career forward.
Books.
Awesome. Well said by the Gabenator.
Sounds like it was scripted by your agent.
That was perfect. Yeah.
Very political.
Your attorney helped you form that one. That's pretty good. He has a non-disclosure agreement with his current employer.
Yeah. Can't talk about things.
That's awesome.
Be vague.
All right, Gabenator, what do we got? What's our first question?
All right, so to kick off the very first question on this 50th episode, we have a question out of Salt Lake City. Mike writes, what do you feel would be more beneficial for a PT that has been practicing for 5 years to acquire? A board-certified specialty, such as an OCS or an SCS, or a manual therapy certification?
Love it. All right, so you're a new grad within your first 5 years. We're a new grad. Okay. What's more important, getting a board specialty through the APTA or getting a manual therapy cert? What do you think, Dave? You want to start off?
Yeah,
Dave and Dan are within 5 years, so this
Yeah.
is good. Let's get your perspective.
So I had friends of mine that went straight from school to their residencies, and they really wanted to go down that path right away. I personally felt like I didn't want to do that super specialized focus right away. I wanted to get a general base and see a range of people, and then kind of decide what I wanted to do moving forward. I knew I always wanted to be in gymnastics, but I didn't know if that was going to be my main thing. So I did a couple of years of just learning as much as I could, taking courses, and then I went back, did my hours, submitted them, and then took my SES, from the 2,000 hours, and then my own course review. So I think that the information in the SES was extremely helpful, but I will admit that I didn't get the hands-on, in the trenches kind of clinical tools that I felt like I needed to kind of treat that population, because it's definitely working in sports. It's harder to do specific manual therapies or know the biomechanics or things like that. So I would say it's really up to what your main goal is, right? If you know oh yeah, I love football, I love baseball, and I'm going to go right at that path, you can do that. But I think that it was better for me to go. I would have rather have shadowed someone on the field for a while and had that mentorship, which is kind of why I started hanging out with you guys a little bit, because I wanted to know, okay, I read this stuff, how does it apply to actual field work?
Right. What do you think, Dan?
Yeah, so I just did my OCS. I thought it was great. I learned a ton, and it was a lot of reading and a lot of application, and I think it was more improving my clinical reasoning. I was just more confident with the patients that came in, just having read so much research and feeling confident what I'm saying. I feel like that really helped the patient with their confidence too. I didn't get a whole lot of manual with it, and I would have liked that, and I've thought about doing the fellowships myself. I've spoken to a few people that have tried to do it. I've spoken to a few of the programs and thought about going through with it. It sounds like you get some pretty good mentorship, but the other thing is I think it's very individual. I think if you find a very good fellowship program that's going to have great mentorship and guidance in the way that you want to be mentored, it's going to be great, and then you're going to have some experience that probably aren't as good because you're not finding that right mentor. So I think a lot of it is finding the person that's going to be the right fit for you, and finding the right program that's going to give you what you need. I can't really speak to which is better, but I will say the OCS prepared me, but not from a perspective of learning tools better manually.
Right.
Yeah.
What do you think, Lance?
I agree, Dan, and I also just take it the next level. Where do you see yourself in 5 years? I'm always looking to see what's the return on my investment. So it's an investment. You're going to spend thousands of dollars to get this done. How is that going to help you where you want to go? Do you want to do a lot of manually based therapy? Do you want to somehow get with a team or something of that nature? So I think it's where you want to see yourself go in your goals as a professional. So.
Yeah, I think it makes sense. I mean, I think personally, from my perspective, you guys said it perfect. I think if you're saying what certification do I want, I think maybe you're thinking of it backwards. Maybe you should ask what knowledge do I want, right. And then does this certification give me this knowledge? Because the certs are irrelevant, right? It's actually you getting, like Dave kind of mentioned, if you want to get into sports, maybe do that. But I don't think your SCS helps you get prepared to go into sports. It's it's maybe part of the process, but I don't think it necessarily helps with that. So I think you got to be careful, and you have to have good, clear intentions as to what you're doing. It sounds like to me a clinical specialty versus a manual therapy cert, it sounds like one is more information that I'm going to learn, and another one is more hands-on techniques I'm going to learn. So if you feel like you're not book smart enough, which I doubt, maybe that's the route for you. But if you want some practice, with your hands, I think that's different. Now, Dan mentioned doing a fellowship, which prepares you for an OCS or an SES. That's different, right? That's like putting them two together. So I think just take a step back and say, what do you want to get out of it? Would be, I guess, my advice. So
That's good.
Awesome, Gabinator. Number 2, what do we got?
All right, number 2 comes from Patrick from Austria. Patrick writes, "Hi, Mike. Love your videos. Thanks for sharing and spreading your knowledge. But I have 2 questions. Number 1, why do the external rotators pull the humerus anteriorly, as you say in some articles? If you look at where they are, they should pull the humerus posteriorly? And number 2, why does the tight posterior capsule lead to anterior translation of the humerus? Thanks a lot."
All right, wow.
I'm Ron Bergen.
So, wow, it took 2 questions there. That's bold. That's a bold move. Who's this, Patrick?
Patrick. Yes.
Patrick, bold move, Patrick, throwing 2 questions in there. So let's see. First question: how's the posterior rotator cuff
Anteriorly?
Pull it anterior. I'm not sure if I've ever said it pulls it anterior. I think to clear that up, I think it's more that it maybe helps centralize or center the humeral head within the glenoid, so that in and of itself, just by contraction of the rotator cuff and that force vector, would help prevent it from moving around. But I think if you're maybe that's where you're getting confused. It's not that it specifically does that. It's that it specifically stabilizes and centralizes the humeral head.
One part of the puzzle.
Yeah, I don't know if I said that well, so I think that just might be off. And then the second part was, what was the second part, Gabe?
Why does a tight posterior capsule lead to anterior translation of the humerus?
Why does a tight posterior capsule lead to anterior translation of the humerus? Anyone want to take that? Or,
Well, I mean, the humerus is going to go to the path of least resistance, so if it can't get posteriorly, it's just going to go opposite, I would imagine, just go where it can. So if you do determine that they have a tight posterior capsule, then there's a chance that they're going to sit more anteriorly. You see that a lot with an older population, the arthritic shoulder. That's where they tend to get tight, and then the humerus is sitting in a kind of a funky position. You can almost see that it's like not centered in the glenoid, and then you start wearing away the other parts of the joint. It just turns into a headache. But I think that's it. It's this path of least resistance kind of thing.
yeah, so I mean, imagine, so if the posterior capsule is tight, imagine you're moving your arm around. Let's say you're going into internal rotation. The humeral head wants to go posterior a little bit, right? But if it hits that tight capsule, it's going to hit it and bounce off and actually go anterior because the posterior capsule is tight. Yeah. So I think that's probably what you're thinking in terms of that, right? So if you look at normal translation in the humeral head, when you externally rotate, you kind of go forward, but then as you continue to externally rotate, you come backwards a little bit and you center after some time. So it goes anterior and then forward, and then posterior, excuse me, as the capsule kind of works as like a buttress to that movement. Yeah. So yeah, I think that's a good question. I mean, clear up a couple of biomechanical concepts. I mean, some of those conceptually are a little tricky, so that kind of makes sense. So nice. All right, Gavinator, what's number 3?
Right, number 3 comes from Brian in South Dakota. I'm a recent graduate and work in an outpatient facility focused on general orthopedics and sports. One thing that I've noticed a great deal of is chronic pain, whether athlete or not. Although so complex, are there any go-to discussions that you have with these patients or things that you notice that work well when treating?
All right, so somebody has chronic pain with some of our go-to stuff. So, and I did in the question you asked too, which was kind of specific. Some people are athletes, I guess we should say. So, I think we can. Why don't we start the discussion off by kind of talking about maybe we can break down chronic pain into a couple of different things. One is maybe somebody that's chronically injuring themselves. So that's a little different. So let's say a athlete, baseball player's shoulder, or a CrossFit person's shoulder because they keep doing things that are aggravating their joint. So that's chronic pain because they keep picking the scab, I guess, right? That's one. I think that's different versus someone that's a little bit more chronic pain in terms of more just
central sensitization.
Yeah, right. Yeah, like actual real chronic
Neural
pain.
changes.
So who wants to start? I mean.
I can weigh in because I've definitely, so when I came out of school first, I was in that general setting, and I definitely kind of swung towards the pain science side. I was seeing a lot of like general low back pain that was very ongoing in nature. So I studied a lot of that, but then as I got shifting more into sports, I found that it was like, I think people are really polarizing on the internet. People are like, there's like a pain science people, there's like the sports med, biomechanical ortho people, and I think that people don't realize that they're way more overlapping than they are differentiating. Yeah. So I've worked with athletes who, the classic example of someone with like low back pain and pain science is like somebody walks in like, I blew my disc out, and the MRI says this, but that happens in a sporting population too. Not all MRI findings are significant, sometimes they're very significant, but I've had athletes come in like, oh, I have a spondy that's like slipping forward a couple millimeters, and like, I'm doomed, I have to quit gymnastics forever. I'm like, I'll just like relax, like you hurt your back yesterday, like let's get through it first, and like you kind of like walk them off the ledge a little bit. So I think that it exists in both, but that person can easily become, like you said, someone who didn't fix their biomechanics and they keep tweaking their back and they feel like they're always in this low lingering state of pain. That's involved in sports as well. So that's kind of my 2 cents on it.
Yeah, I think I was in a similar place. I saw quite a bit of fibromyalgia, CRPS, and I actually really liked that population. It's kind of fun to work with. I don't know if that's what you're talking about, and I agree with Mike, you have to figure out what you're working with. But I think that even if you are dealing with a patient like that, the biomechanics are still important. You should still make that part of your examination. But once you figure that out, a few things that I think work really well are just developing some goals. A lot of times these individuals are stuck in a pattern of whatever it is. Yeah, their hopelessness. We want to try to make sure that they're working towards something they enjoy and they have a sense of hope and a sense of this can actually get better, which is really good. I think the other thing that's important for these individuals is that you have to look at their lifestyle on a regular basis and just make sure that they're not continually irritating. A lot of times, and I just had a patient like this yesterday, is that they keep on just plowing through all their regular activities because they know they need to get things done. But going to the grocery store for a chronic pain patient could be too much for them, right? So if you think about that potentially biomechanically, it's like, well, maybe you need to go to a smaller store or shop twice a week or something like that. So the thing that I've found a lot of success with these individuals is not necessarily just getting them on an exercise program and getting moving. That's obviously very important, but it's breaking up their week. It's like if you're going to exercise on Monday, maybe you shouldn't shop on Monday. Maybe you work that into your Tuesday and you set up your week that way. And there's obviously a lot of things you can do, but that's probably one of the first things I would do with my patients, just educate about that and try to set up on a plan that works towards their goals and works their lifestyle into a plan that works.
Yeah, well said. I mean, Dave said it well. I mean, if you can follow people on Twitter and think that pain science is the most important thing that we should be focused on, but I think that's only on a certain percentage of population or so. If you try to do that on the masses, I think you're gonna really swing and miss. I know I've had a couple of episodes in my career where I had complete chronic pain people where it wasn't responding and it wasn't orthopedic, and that's not my wheelhouse. So I tried to approach it with like a pain science conversation, and it never goes well. Trust me, I did it way better than probably most people, perceive that it should be done on Twitter, at least. But they still, I think the person was looking for help, right? And trying to tell them that it's in their head or it's a perceived threat and those things. I mean, sometimes you got to be careful with that type of thing. So I think the key is finding the balance on how to build that into your program. But realistically, there's a big difference between the chronic pain person and somebody that really has a problem. The problem is when we try to apply pain science to somebody that has a real problem. Yeah, that has a legit biomechanical structural problem. I mean,
your shoulder dislocating is very threatening.
Yeah, we kind of had this conversation yesterday with somebody. You sprained your AC joint checking somebody into the boards. Okay, you're a hockey player. I mean, I don't think we have to look at your diaphragm. I don't think we have to talk about pain science. You just smashed somebody into the boards and popped your AC joint. So let's focus on what matters with that. So, I think that's how you have to look at chronic pain. And the athlete, the athlete that has chronic pain, to me, is probably someone that just is chronically beating themselves up. I think that's different. You try to do pain science on them, that makes no sense. Yeah. Right. So, you got to be careful. I
think an important thing, kind of dovetailing off of these guys, is just connecting with the patient.
100%.
As a PT, you can quickly understand what's going on with somebody, just getting a good subjective and hearing their story, and you need to really give them not just information about pain science, but I think giving them hope, giving them a feeling that you can help them, even if it's small incremental steps, that you understand what they're going through. I think it's the whole empathy thing, sympathy thing, whatever the two differences, empathy, and just give them hope. You understand their issue, and just giving them small incremental goals, like Dan mentioned, but the small goals. It may seem small to you, but just give them a goal, and they hit it, and then you are super positive. Like, you pump them up, you get that adrenaline rush or the endorphin release. They need that positive nature in their life. They don't have it. They are spiraling down, and I think just giving them hope is huge for us. And I think we do a pretty good job here, despite us seeing a lot of athletes. We do get the chronic pain person that is searching the internet for help, because they've been everywhere, you know? So.
And I would say the last little piece that I have is that whether you're a sports, biomechanics, orthopedic, oftentimes you get in a rut of hearing keywords and jumping directly to something.
Yeah.
So you hear, like, I've had back pain or fibro, and instantly your brain thinks, like, oh, chronic pain, and you start giving them this spiel.
Yeah.
Or same thing with biomechanics, you give them this spiel, right? But, like,
let them tell their story.
Exactly. You took the words out of my mouth. Like, let them tell you, and you'll pick it up right away. Whether someone like, okay, we're gonna go a little easier today, just talk generally.
Yeah.
I think in this, sorry, too much time on this, but in the chronic pain population, building rapport is huge.
Yeah.
And I think the research also supports that for outcomes. So just building really good rapport with those people is important.
Definitely.
Awesome. Yeah, good answers. I like it. Perfect. Awesome. That's 3. That's a wrap. We appreciate it. Thank you so much. Thank you, Gabe and Ader, everybody. Give a round of applause.
Thank y'all for having me on.
Yeah, the Gabeinator.
Fist
Thank
bump,
you so
Gabe.
much.
Fist bump.
50th episode again. Thank you so much for joining us on this this ride that we're doing here, and a good year of podcasts under our belt. So if you like it, please subscribe. Go to iTunes, rate us, review us, whatever the heck you're supposed to do, and go and ask us questions on
Send Mike fan mail.
MikeReinold.com. Click that podcast button, and hopefully we will keep getting some awesome questions. So thank you so much, guys, and we'll have another special episode on the 100th episode, right?
Okay.
Wow.
Awesome. Thank you.